So we're going continuing our talk about blast injuries. So the biggest thing that we worry about more so than anything else is pulmonary injuries that occur, particularly arterial air embolism. So if you have alveolar disruption, meaning a break in the membrane, and then you can get air embolism that will travel around into the pulmonary vasculature. Some of the things that it produces: disturbance in vision, changes in behavior, changes in the state of consciousness. And then there's just a variety of other neurologic signs, but this can be life-threatening. Solid organs, they tend not to have too much of an injury just from that initial shock wave. If they're going to be injured, it's typically because of the secondary, tertiary type of injuries when the body is hurled through the air or when something else flies to it. Neurologic injuries, head trauma are the most common cause of death from blast injuries. And extremity injuries, including like traumatic amputations, are relatively common as well, but they tend to be more visually graphic than anything else. Multisystems trauma, this involves more than one body system, just as it says. So head and spinal trauma, chest and abdominal trauma, chest and just multiple extremities. You need to let medical control know and transport rapidly. Oftentimes it's going to take a full team of people to be able to care for these patients. So making sure that they have all the resources available when you arrive, definitely something you need to know. Some of the governing principles that we have for pre-hospital trauma care, again, main priority is safety. Safety of all of us working on the scene, and then safety for the patient as well. Determine your need for additional personnel or equipment. Sometimes it's just something we can't handle, either the safety of the scene or the actual patient themselves. Evaluate your mechanism of injury. That helps you determine those injury patterns. Identify and manage your life threats, which you find during that primary assessment. So your ABCs, and then treating for shock. Most of the time with trauma, we're going to be utilizing spinal immobilization. So getting that applied very quickly so that you can get the patient out of there. And then, of course, transporting to the appropriate facility. In most patients that have multi-system trauma, their definitive care is going to be surgery. So we don't want to play around on scene a lot. We want to try and limit it to 10 minutes or less, because there's not a whole lot that we're going to do in the field that's going to make a massive difference in their care. Yeah, we can support blood pressure. Yes, we can treat pain with ALS on scene, but really in order to fix their problem, it's going to be surgery. You can obtain your sample and your secondary assessment, all of your history questions while en route. You don't need to do that on scene. And depending on the situation, you might want to consider ALS or an air medical transport. For your patient assessment, we're going to consist of all of the different categories, just like anything else. So scene size up, primary, history taking, secondary assessment, and reassessment. When you have a patient that has had a serious MOI and the patient's considered to be serious or critical condition, the physical exam should be pretty quick. That head to toe should take 90 seconds or less. But you want to make sure that you go through and that you don't miss anything. When the patient has experienced a non-significant MOI, you can focus on that chief complaint itself. For injuries to the head, disability, unseen injuries to the brain can occur because of that coup counter coup motion. And the brain does not deal well with swelling because the skull is rigid. It doesn't give a lot of give and take. So any sort of bleeding, swelling is going to be relatively life-threatening. So all of our assessments should have a neurologic exam um, to try and pick up on those things. Some patients have no signs or symptoms. You're just kind of shooting in the dark here, but they'll do CTs and MRIs in the ER after you get them there just to double check. So we don't want to spend a lot of time in the field. We want to get them somewhere for definitive care. Injuries to the neck and throat, the biggest problem here would be airway problems. The trachea can become torn, it can swell, which can become a serious life threat. Um, our assessment, we're going to look for DCAT BTLS in the neck region, and then also assess for jugular venous dissension, tracheal deviation. Remember that tracheal deviation is not clear up at the thyroid cartilage, it's down at that suprasternal notch. Any swelling in the neck is not just going to affect your airway, but it can actually prevent blood flow to the brain as well. Any penetrating injury may result in an air embolism. In order to protect from this, we're going to use occlusive dressings, and we'll talk about that a little bit more in subsequent chapters. Crush injuries to the upper part of the neck may cause the cartilage of the upper airway and larynx to fracture, and that can cause significant compromise to that airway. Injuries to the chest, remember that your chest contains some pretty big structures, your heart, your lungs, large blood vessels. And then even if you're not messing with those large structures, you can still have some pretty life-threatening injuries. So broken ribs themselves, yes, they have the ability, excuse me, to affect the lungs, vessels, etc. But even if they don't affect any of those underlying structures, they're significantly painful. And so patients may not want to take adequate breaths. So now they're hypoxic and their body will want to fix those breaths, but that pain is going to become a huge issue. Bruising may occur to the heart, causing irregular heartbeats. Large vessels of the heart may be torn, causing massive bleeding. Air collecting between the lung tissue and the chest wall is called a pneumothorax. And then any penetrating or perforation in the chest is called an open chest wound. You may have heard it called a sucking chest wound. If left untreated, shock, death will more than likely occur. So it's imperative that you assess the chest region every 5 minutes, which should include looking for DCAT BTLS, lung sounds, and then adequate and equal chest rise. Injuries to the abdomen. Your abdomen contains a lot of vital organs, a lot of blood flow to perform necessary functions. Your organs of the abdomen and then the retroperitoneum can be classified in 2 categories, solid and hollow. Your solid organs are like your liver, your spleen, your pancreas, your kidneys. Your hollow are your stomach, large and small intestines, and then of course the urinary bladder. When you have injuries in this region of the body, not only is the injury itself serious, but then you can also have a lot of secondary issues that can compromise the patient. So like your hollow organs typically have enzymes, different fluids inside of them. And so if those rupture and leak, you may end up getting all of those toxic chemicals, digestive juices and whatnot, just hanging out in your abdomen, which can cause a lot of problems, including life-threatening infection. You have a lot of blood vessels because you have a lot of organs, so you can have serious unseen bleeding, so we want to continue to assess. Management and transport. Call early for ALS and helicopter, but try to avoid delays in treatment and transport. Like I said, your scene time, we want to limit that to 10 minutes because if our patients are going to survive, they need to get to definitive care. Your type of transport, you can certainly go with ground EMS. If you have EMTs, if you have paramedics, you might need to call for ALS if you don't have paramedics on staff. Destination selection around here, you don't have a whole lot of choice. We have 2 level 2 facilities in Avera and Sanford, and then critical access hospitals elsewhere. Um, each one is categorized because of what resources they have. Your level 1 facility is normally large cities, provides every single aspect of trauma care, and most of them are university-based teaching hospitals. Your level 2, less populated areas, but does provide that initial definitive care. Your level 3 provides assessment, resuscitation, emergency care stabilization, and then transfers the patients to a level 1 or level 2 center. Your level 4 facility is pretty remote. There's no higher level of care. They provide trauma life support and then transfer to a higher level of care. And here's kind of your graph of how that is laid out. And this is, of course, in your book, so I'll let you go ahead and review that. For your special considerations, remain calm. Make sure that you complete a thorough, organized assessment so that you don't miss anything. Correct those life-threatening injuries. The secondary, yeah, a broken arm, a broken leg, they can look pretty gruesome, but oftentimes they're not going to cause your patient life threats. It's going to be those underlying stuff that you can't necessarily see. So a good thorough assessment is absolutely necessary. Do no harm. Patients are often going to be in quite a bit of pain. And yes, it sucks. You're going to have to talk them through, hey, I've got to do this. I know it's hard. Talking to them in a reassuring tone, calming them down can do a lot for pain management. Positioning can do a lot for pain management. Ice packs as appropriate can do a lot for pain management. If you can't manage the pain, you may want to call ALS in. For patients that are experiencing problems with blood pressure, remember the treatment for shock, oxygen, keep them warm, and you may need to call ALS for blood pressure support, but you don't want to delay treatment. Even with some blood pressure support, if we don't stop the bleed, then your patient's not doing any better. So if it's a choice of ALS or getting them to the hospital in the same amount of time, you're going to have to use your best judgment. This is the last recording for chapter 24. We will continue on with the next chapter.